what happens if a lot of people sign up for the public plan and then doctors don't participate, like has happened with Medicaid? There are many places in the country where people call up and say to the office and say, do you take Medicaid? Does your doctor take Medicaid? And do you know anybody who does? So what happens if, I mean, why is it going to be attractive for doctors to, they might not want to participate, and then if a lot of people sign up and then doctors don't participate, then they might be, you say you could leave the public plan, but
no, the solution for that is simply to raise reimbursement for physicians.
Okay.
It doesn't cost a lot to pay primary care doctors more, because they're not the high-end chargers. You could raise everybody's primary care rates by 25%, and you'd be far from bankrupting the system. That's not where the big bucks is.
Right.
The big bucks, in fact, people blame the specialists all the time. Even that's not the big bucks. And the drug companies, that's 10% of our total outlay. The big bucks is in procedures. That's where the really huge bucks is, and hospitalization. And that's where you got to look for the big savings. So you're right, and the market does work there. Eventually, and that's where I just said, one of the former speakers said, well, we should just have Medicare be needs tested. I think that's a terrible mistake. You want everybody to be in the system, because if everybody who wants to be in the system is in the system, then Congress has to respond. If it's just a program for poor people, they can kick the folks to the side because they don't participate in the political process as much. So if everybody's in the system, and people like you all are coming up and complaining about reimbursement and you can't find a doctor, the government has to do something about that. And some of the measures we've talked about, expanding the number of primary care people. Look, when we made health insurance, the way we made health insurance available to everybody under 18 in my state is to expand Medicaid to make it a middle-class entitlement for people under 18. If your family today in Vermont makes less than $66,000 a year, your kids are entitled to insurance as many as you have for $480 a year. Why? It doesn't cost much to take care of kids. We didn't even have to raise taxes to do it. But we did have to raise reimbursements to pediatricians, because now we're increasing the Medicaid percentage of pediatricians dramatically. And if you don't raise their reimbursement, now pediatricians are the nicest doctors in the whole world. They are. They are. They're just wonderful, wonderful people. They get paid less than anybody else except maybe psychiatrists. Don't ask me why that is, and I'm not making any judgments on average. But if you don't, people have to be able to run their business, and it is a business. So we've increased the rates significantly to pediatricians, and it seems to be working. Last one.
Hi, Dr. Dean. I was wondering if you could comment on how you think the insurance companies predict maybe how they'll behave if you move from a private option to the public option. Will it force them to be more competitive, or will they start drumming up new ways to exclude people who dissed them and moved over to the other side? Thank you.
Well, the bill right now calls for them to play under the same rules. The same rules gig goes two ways. The Congress wants the public insurance option not to undercut them by using government subsidies, but the government option takes everybody, and that's part of the rules they're going to apply to insurance companies. Just here's a little fact that's in the book. There are two European systems, which are almost all of which are universal. The Netherlands and Switzerland, which actually don't have a public option. It's all private insurance companies. However, they treat the private insurance companies like regulated utilities. They tell them how much they can make and what their salaries can be and how much they can charge. I often think we ought to put that on the table. No public option. Let's just put the Swiss system in here. Believe me, they'll all be for the public option as fast as they possibly can be, because they have to actually compete. There's not much regulation. But the two pieces of regulation are guaranteed issue and community rating. Now, the community rating in our state is a 20% band. That is, you can't charge the sickest person 20% more than you charge the healthiest person. That band has worked, and the insurance people who have stayed in our state are pretty good insurers. In the House bill, I think it's or the Senate bill, I'm not sure which, it's 100%. That's too big. You shouldn't be able to charge one group of people 100% more. This is an insurance business. It's not just a profit-making business. And you got to think about real insurance. So the band, I understand that there has to be one, but it should be narrow. But so the argument against the idea that people will be able to dump their folks into the public option, the insurance companies, and we'll take all the risk. First of all, if we did, it'd be fine, because these people have to have insurance. and maybe that would make the insurance companies a little calmer in terms of how they treat people. But they can't. If guaranteed issue and community ratings pass, they have to take them all, so everybody should theoretically have roughly the same risk pool. Now, it's not exactly going to happen because there's obviously a preponderance of people who are already ill and who have disabilities of various kinds in the uninsured population because they can't get insurance. So there will be some risk increase in the public option. The other thing that happens in the European system in Holland is that the insurance companies have to take the same risk, but if some of them end up with a higher, more risky group of patients, the government actually pays them more than the companies that exclude. So there's a leveling effect. There's lots of ways to do this, and none of them are rocket science, and there already exist in other models. But I think it's very unlikely that we're going to end up with a system where we take all the risky patients. There are a lot of risky patients now in group insurance. Group insurance is a much better deal than individual insurance. And group insurance that's self-insured for very large companies is the best deal of all. You get a job with IBM, you're going to get their health benefits, and they're not going to charge you any more than they charge somebody else. Or any number of Microsoft or any number of another zillion companies that have these big group self-insurance plans. That's not a bad way to run health insurance. In fact, there are some employer-based systems throughout the world that work that way. Germany works somewhat like that, except that it's done through guilds or something like unions. The bottom line here is that, and I'm just going to do this for the closeout, the public option is something that's not new. Everybody over 65 is in the public option. So the question is, are we going to make people under 65 eligible for that kind of health care if they would like to make that choice? And if you do that, will there be some adjustments down the road? Yes. Will there be some problems down the road? Yes. But if you don't do that, no matter what they do, if they don't do at least that, we are condemned to the system that we have for the foreseeable future. That is not sustainable. Thanks very much.